aspirations in revision total knee. I mean, it's quite a narrow topic to cover in 12 minutes. So what I thought I'd do is break it up. I'd try to achieve three things. The first thing I was going to do, there's my consultants again, was I was going to just present to you two studies that were presented at this year's Knee Society that were both award winners. And then I was going to try and cover two smaller topics, a little narrower, a little bit about stems, a little bit about constraint, see if you can take some take-home messages. I devised this plan before I realized that Dr. Parvizi was one of our guest lecturers today. In both of the studies, he's a author on. It's difficult actually to find a study in arthroplasty these days that Jay's not an author on. But so I apologize in advance if I misstate these studies. This one, it's actually it was the 2010 Knee Society. So just last month at the Academy on Knee Society Day, this won the Coventry Award. It was a multi-center study. And it looked at the diagnosis of early post-op infection following primary total knees, trying to look at synovial cell counts and differentials. Because we've seen over the years many papers published on how you use cell count in the diagnosis of a chronic knee infection. And the thought here was, well, what if I have a patient that comes within 6 weeks after surgery, and I draw an aspiration, what can I make out of that cell count? And is it the same as the papers that have been published over the last 10 years? So I really found this quite interesting because it's a scenario that we're faced with on occasion. So this was a multi-surgeon, multi-institution review of nearly 12,000 total knees. They had 146 knees that were aspirated within 6 weeks of total knees, of which 19 turned out to be infected and 127 were non-infected. They did a lot of fancy statistics, some of which I don't understand, but they eventually came up and said that the optimal cutoffs to determine infection were a white cell count of 27,800, 90% PMNs, and a CRP greater than 95 milligrams per deciliter. And that if you were to use your standard cutoffs that we've come to understand, and Bo Mason's published on it, I think Jay's got a paper on it, Craig Delavalle's got a paper on it, that range anywhere from 1,800 to 3,000, it would have led to several unnecessary operations in that early postoperative period. So these are different cutoff values for those early aspirations in the first 6 weeks after the surgery. This is the second paper that I found interesting. This was Tom Faring's group, another multi-center study from several institutions. And this is the fate of two-stage reimplantation after a failed IND for periprosthetic infection. So once again, multi-center study over many years. They took all of the patients that initially underwent an IND that failed and went on to two-stage reimplantation. They came up with 92 patients who had failed that IND and subsequently had the two-stage, and of those 92 patients, 28 of which failed their two-stage revision. So it's a 30% failure rate for these two-stage revisions, 14 INDs, and you can see the list of several catastrophic outcomes. So while not only does IND have a poor early success rate, but their thought was that it may actually compromise the success of the subsequent two-stage revision. I'm not sure if we can draw that conclusion, but certainly it gives you second thoughts about doing that initial early IND, knowing these results. So just once again, to summarize those two studies, if you're going to take something home with you and you're an arthroplasty surgeon, you see a patient within 6 weeks of surgery, if you can remember these numbers, that if I aspirate the knee, the cell count, which is the white counts of somewhere in the ballpark of 30,000, is going to indicate infection. And the nice thing about their study was they really had two, they were either really high or really low. And anything under 10,000 was non-infected. And secondly, if you decide to do an IND and that poly exchange fails, and this is kind of how I interpret that study. If I do an IND in the early post-op period and I exchange the poly and then it goes on to failure, that's just a different conversation that I'm going to have with my patient, because normally what I would do is I'd say you got a 90% chance of success with a two-stage reimplantation. That's what I would normally tell a patient. But in this scenario, knowing this data, I'd probably change my explanation and say, you're a bad player, and I think your success may be closer to 70%. So I think that's probably the value that comes out of that. So let me talk a little bit about STEM. These are like two of the things that my fellows ask me about most commonly, and I often wonder about when it comes to using STEMs in revision as well as constraint. We'll talk on just a few of these subjects here quickly. In general, we know that stems in revision arthroplasty increases implant fixation and stability, but there's really no consensus on what to use for your straightforward revisions. And when you don't have significant bone loss and you don't have significant defects, there's really no guidelines on what stem length to use. Do you cement it? Do you not cement it? What diameter do you use? So I'll try and outline some of what we know so far. When you use a cementless stem, we know that the cementless stem, if you use it correctly, will dictate both femoral and tibial component positioning to a much greater extent than cemented stems. And in general, the tibial side cementless stems, you want to go longer on the tibial side to improve your varus valgus alignment, because many people actually have a tibial bow. So if you use a shorter femoral stem and only engage the top of that bow, that can leave your tibia in some valgus. This certainly, some would say, is favored in the treatment of two-stage infection simply because of the ease of removal of re-revision. Certainly the cemented stem advocates would say that they can deliver antibiotics, so they favor it. So that is up for debate. Let me go back there. Cementless stems and even cemented stems, but I think to more an extent cementless stems may cause end-of-stem pain, and of all the designs available today, do not provide long-term biologic fixation. Cemented stems are more forgiving relative to implant positions, so you're not relying on your canal to buy the implant position. You can certainly achieve immediate secure fixation, certainly seems to be favored in situations of poor bone quality, and you can deliver local antibiotics. But it can lead to some stress shielding at the proximal femur or tibia, and this can really be a bear if you have to dig out an abundance of cement around the proximal tibia or distal femur. This is Bob Barrick's paper where they did a prospective review of revision total knees and looking at end-of-stem pain and showing that up to 19% of patients got end-of-stem pain. I've certainly seen this in my own practice. He didn't see any correlation between stem diameter and the occurrence of pain. When it comes to the whole do you cement or use cementless stems, I think there's really two institutions that favor the use of cemented stems, the first of which is Tom Ferring's group in Charlotte out of Ortho Carolina, and this comes from their paper in 2003 where they looked at cementless stem fixations and revision total knees. And when they used revision cemented stems, they had 93% stable components, but when they used cementless stems, they had much poorer result. 71% were stable, they had nearly 20% were loose, possibly loose, and 10% were in fact loose. So Tom does favor cemented stems, but he also says that this was really with the metaphyseal cementless stems. So I think that, if you were to ask him, he doesn't mind cementless stems, but he really emphasizes that if you're going to use a cementless stem, you've got to get into the diaphysis and good diaphyseal fixation. So I think that's the real take-home message from this paper. The Mayo Clinic really doesn't waver. They favor cemented stems, and it comes from their paper. This is one of their papers, 63 revision total knees using cementless stems, and they had at 6-year follow-up nearly 16% mechanical failure rate. So if you ask Arlen Hansen, he really doesn't have a strong opinion about anything, but he definitely favors the cemented stem. When it comes to stem length, there's different criteria. When you use a cemented stem, you certainly don't have to go nearly as long, but I would think you'd want to go longer, at least into good bone, past some of the bone lesions. But on the cementless stem, if you're going to use a cementless stem, I do believe you have to get into the diaphysis to reap the benefits of that stem. So, which to use? If you're going to use cementless stems, once again, diaphyseal fixation, I would be careful of how the stem influences your component position, because it can throw you off if you have bony abnormalities proximal to the prosthesis. Cemented stems, you want to use shorter than cementless stems. I would caution you, do not use a cementless stem in a cemented application. I've seen that walk into the office, and that's not a good idea. It certainly allows more flexibility in implant positioning, and you can deliver antibiotics with this construct. So, what about constraint? This is something that I deal with constantly when I'm doing revisions. How much constraint do you use in any given revision case? Here would be all of your options. PS, varus valgus, constrained hinge, or distal femoral replacements. And the question my fellows often ask, well, why not just put in more constraint? I mean, why not use the CCK in this case? Why not use the VVC implant in this particular case? And we know that throughout a range of motion, the normal knee rotates up to 17 degrees, internal and external rotation, that screw-home mechanism that we know about. But these prostheses really do not allow much rotation. And these are different designs from different manufacturers, but plus or minus 2 to 4 degrees of rotation as it goes through a range of motion. So we know that those forces have to go somewhere, and that certainly would worry me in a lot of these cases. So a lot of these forces are out-of-plane forces, and they've got to be transferred somewhere from that post to something, and it's usually to the mechanical or the interface between the prosthesis and bone, many of which these interfaces in these cases aren't particularly good. So I just worry that it would lead to premature implant and fixation failure. It oftentimes leads to patients, when you lack any rotation, they get what is referred to as a very mechanical knee. So in the traditional principles, when you're trying to decide how much constraint to use in a particular case, I think if you've got good collateral function, if you've got good flexion extension gap balance, and you can get away with a PS design, you could even get away with a cruciate retaining design. I think if you have moderate collateral laxity or incompetence or problems with your flexion gap that you simply can't get it perfectly balanced, then I think you're looking at one of these constrained devices, whether it be a TC3 or a CCK, where you get a bit more varus valgus constraint in the box and a higher post to avoid jumping the post. When you have complete collateral loss, severe bone loss, or recurvatum, in these cases I think you're looking at going towards those rotating hinge devices. Here's some examples. This question would be, in these severe biplanar deformities, do you use a PS or varus valgus constrained device, fixed versus mobile bearing? And this one, when you release it enough, and also depends on the age of the patient, then we go with the TC3 device in this particular patient. Here's another patient in 18 degrees of varus, fairly stiff, able to get away with a PS device. So I don't think there's any hard and fast rules. There's judgment that goes on during these cases, certainly. When it comes to varus valgus constrained implants, these are used to augment ligament stability. So if you're doing a severe deformity and you do an intra-op release, but you still have an MCL, I think you can use these devices. Or if you have pathologic stretching, especially on the valgus side with severe valgus disease, or if you have poor flexion gap control, which I would caution you never want to leave a patient with poor flexion gap control, but in certain cases you simply can't chase it down, then the varus valgus constrained implant is your go-to implant. But I think it's important to note it will not compensate for substantial ligament deficiency. Here's an example of a patient with very poor flexion stability, and in that patient, one of these varus valgus constrained devices would be required. When you're trying to determine whether you can get away with a TC3 or a varus valgus constrained device versus a hinge, I think the hinge plays a role with gross ligamentous incompetence, whether it's pre-existing or iatrogenic. If you have a severe fixed deformity, like if I've got a valgus over 30 degrees and a complete loss of the MCL, then I'll consider, especially in the elderly patient, going to a hinge device, or severe bone loss in the low-demand patient with compromised ligament attaches. These tumor-type prostheses are traditionally used only with substantial bone loss or maybe in the face of a distal femoral periprosthetic fracture. So key take-home points from that segment: re-revision for instability is actually fairly common. We know that when you look at the causes of failures. You should appreciate the differences between pathologic ligament laxity and insufficiency, especially on the medial side. Joint line elevation will magnify this instability. This is, I guess, a slide from a DePuy talk on mobile bearings, but I certainly am a DePuy consultant, but I do favor the mobile bearing device in some of these big revisions because it takes some of the stresses away from the implant interface. And I think if you follow a good stepwise approach and follow some of these principles, you're going to have reasonable results. Thank you very much.